Good evening, everyone. My name is Susan Holtzman, and I'm the president and CEO of the NAMI Miami-Dade and Monroe County affiliate of the National Alliance on Mental Illness. And so we provide education, support, and advocacy to people living with mental health conditions and their loved ones. So if you're here with us tonight, you may know all about NAMI, but if you don't, if you're new and someone shared this information with you, you can go to namimiami.org to get more information. So we have a great program this evening. We're very excited to have two guest speakers. So I'm going to introduce both of the physicians that are going to be speaking with us this evening about tardive dyskinesia. So first we have Dr. Nicholas Lukish. Dr. Lukish is a first-year psychiatry resident at the University of Miami-Jackson Health System who completed medical school at Kansas City University and Bachelor of Science in Neuroscience at Johns Hopkins University. His clinical interests include personality disorders, interventional psychiatry, PTSD, psychotherapy, trauma-informed care, medical education, healthcare business operations, and the culture of medicine. Prior to medical school, he worked for 3 years as a healthcare process improvement consultant at Huron Consulting Group. Welcome, Dr. Lukish. And we also have Dr. Angelica DiLorenzo. Dr. DiLorenzo is a second-year psychiatry resident at the University of Miami-Jackson Health System, where she is part of the psychodynamic psychotherapy track and has been recognized for clinical excellence during her training. She earned her medical degree from the University of Lublin, and Dr. DiLorenzo, is actively engaged in academic psychiatry with multiple publications and national conference presentations. Her clinical and scholarly interests include psychodynamic psychotherapy, consultation liaison psychiatry, trauma-informed care, and the mental health needs of the underserved and marginalized populations, where we at NAMI are also doing quite a bit of work. That includes her work conducting psychiatric evaluations for asylum seekers through the Human Rights Clinic of Miami. So welcome, Dr. DiLorenzo.
Thank you. I'm glad to be here. Hello, everyone. All right. So what we're going to do is we have a PowerPoint presentation to share with you guys. And we are going to let Dr. Lukish start us off.
Perfect.
All right. Perfect.
All right.
All right. Take it away, Dr. Lukish.
Thank you. Well, thank you, Mrs. Holtzman, and welcome everybody. I'm really glad you're here today. This session is designed for patients, family members, really anyone who wants to better understand tardive dyskinesia, often called TD. Our goal is simple. We're here to just help you understand what TD is, why it happens, what symptoms to look for, and what treatment and support options exist. So hopefully by the end of this talk, you'll have a clearer picture of TD and feel more confident navigating conversations with your healthcare team. So let's go to the next slide. So this is just an overview slide of some of the things we'll cover in the presentation. Just from a high level standpoint, tardive dyskinesia is a movement disorder. It's characterized by uncontrolled body movements, and it's often a side effect of long-term use of dopamine blocking medications such as antipsychotics. So we'll talk about the causes, some of the side effects, common triggers, some risk factors, recognizing this, and then also Angelica, Dr. DiLorenzo will talk more about support, communication with your healthcare provider. So let's go to the next slide.
Two passengers on the phone.
Okay, so like I said, TD is a movement disorder. It's caused by the body when the body makes a range of uncontrolled movements of the mouth, face, tongue, trunk, arms, or legs. It's not something a person can choose to have or control. These movements are involuntary, meaning they happen on their own. And TD is a side effect of certain medications, especially medications used to treat mental health conditions such as schizophrenia, bipolar disorder, severe depression. With that said, it can also occur as a side effect of some medications for stomach issues like that you would take for nausea or reflux. The name itself helps explain the condition. Tardive means late. The symptoms appear after someone has been on the medication for a while. And then dyskinesia means abnormal movement. So essentially, TD is a late appearing movement disorder caused by certain medications. Go to the next.
Okay, what about the mind?
So let's talk about what causes TD. So it should be, it's important to note that all dopamine blocking agents have the potential to cause TD in susceptible people. So these medications block dopamine, which is a chemical in the brain that helps control movement, mood, and motivation. The most common medications that lead to TD include antipsychotic medications, some anti-nausea medications like metoclopramide, and then pro-motility medications. Not everybody who takes these medications will develop TD, but certain factors certainly increase the risk of TD. And we'll go to the next slide to talk about that. I think we're better now.
Yeah, good.
So when does TD happen? One of the most confusing things about TD is when it appears. So TD can develop months to years after starting antipsychotic therapy or another dopamine blocking agent. And so symptoms don't usually show up right away. They can also appear when the medication dose is lowered or stopped, which can surprise people, but it happens because the brain's adjusting to changes in dopamine levels. So the symptoms themselves can be subtle and fluctuate. They can be easy to miss at first, better on some days, worse on others, affected by stress, and go away when you're sleeping. So this is why regular screening for TD is so important. So we can go to the next. So what are the symptoms? So there's a variable spectrum of symptoms for TD. TD can look very different in one person to another person. Again, it comprises a variable spectrum. So some of those most common examples include making unusual or repetitive facial expressions, sticking the tongue out, moving it around, pouting or puckering, smacking the lips. Certain finger movements are common, sometimes described as like playing the piano. Jerking or twisting movements in the legs or the hips. Again, it's important to note these movements are not intentional. They can be embarrassing, sometimes frustrating, misunderstood by others. And it's important to also note that TD is a clinical diagnosis, meaning there's no test that can confirm it. It's recognized based on timing and presentation, so how it appears, and you need a physician in order to make that diagnosis. Okay, and so now I will hand it off to Dr. DiLorenzo for the rest here.
Thank you so much, Dr. Lukish. Hello, everyone. As stated, I'm Dr. DiLorenzo, psychiatry resident. So, I'm really going to talk about the kind of prognosis and treatment of tardive dyskinesia. And I think what I very much want to emphasize is that this is a medication side effect that occurs from either long-term use of these dopamine blocking medications, which for the purpose of NAMI and this lecture is most commonly going to be antipsychotics in this population. And antipsychotics are very commonly used in patients who have schizophrenia, schizoaffective disorder, bipolar disorder, and even can be used for depression and anxiety. And so what's important to understand is that this is a medication side effect, but I do not want anyone to be afraid of taking medications that are overall going to be improving their quality of life. So unfortunately with TD, the side effect is usually irreversible and lifelong, although it can improve with the use of medications specific for tardive dyskinesia. And what's very important is noting that it can happen either with long-term use of dopamine blocking medications, but it can also happen if you abruptly stop taking a medication that is dopamine blocking after a long time. So I'll go forward. Let's talk about how it's treated. So it's going to be dependent on the severity of symptoms. So as Dr. Lukish kind of described some of the symptoms, patients who develop tardive dyskinesia, usually months to years, although it has been shown to be a little sooner in patients that are over 60. So these movements can be, yes, embarrassing. They can be, stigmatizing. And they can be a little bit annoying because they're difficult to control, but they are not life-threatening. This is not something that is going to harm you, but that doesn't mean it's not a painful side effect and it's not a frustrating thing to experience. As Dr. Lukish said, they're often worse under emotional stress and improved when you're feeling a little bit better, and they also go away when you're asleep. And a lot of times these do come on gradually, and other times they can be really insidious. So let's talk about what we can do. So let's say that you're somebody who has been on a medication like risperidone for many years, and it is doing an amazing job at controlling your symptoms. And the risk of going off of the risperidone or switching the medication, which, as I'll talk about later, risperidone is actually has a very low risk for tardive dyskinesia. We can actually add these FDA-approved medications. So there are two, they're listed right there, Austedo and Ingresso, or whatever it's called. I don't know if I'm pronouncing it right. They're VMAT2 inhibitors. VMAT is basically a vesicle, without getting too into the complications of it all, it can really help improve or alleviate the symptoms. Now, if you're on your medication and you're on this FDA-approved medication, still not doing well, we have a next option. We have clonazepam, which is a benzodiazepine, and we also have this natural substance called ginkgo biloba. And I do want to always mention, because it's very popular and common to be able to order supplements over the internet and think that they're safe. You should always be speaking to your physician, especially if you're on medication for psychiatric disorder, before starting anything over the counter, even if it's listed as safe. And then as we go on with like level C, level U, this is if, these are last resorts. And I think rather than focus on the fact that it might get to this level where you need further and further treatment, I do want to emphasize that this is basically stating that if you develop tardive dyskinesia, there are so many options for you that are not about either like restarting a medication, because I mentioned in some cases, it's about restarting a medication that is dopamine blocking or stopping. So we can also use these medications, the ones that are listed there, we actually use for memory disorders and for Parkinson's disease. And we can use brain stimulation and eventually switching to other medications. So can it be prevented? There is not a prevention. We do not know who is going to develop this and who is not. There is not a proven genetic component or a predisposition that means that you're going to develop this while another patient may not. But you can lower your risk. What's most important is going to be this regular follow-up. Now, regular follow-up is not just important to make sure that you're not developing any side effects from medication that can include tardive dyskinesia, but it also is making sure that you are always on the right medication. I want to emphasize that antipsychotics are not just used for schizophrenia, bipolar disorder, and schizoaffective disorder. A lot of times we have patients with substance use disorder that might have been ingesting amphetamines or cocaine for a long period of time. And we put them on antipsychotics to help alleviate these symptoms of psychosis that are temporary and that will go away with sobriety time. And so that's why it's really important to keep up with your provider, because you may not need to be on this medication for the rest of your life. And at the same time, we also have patients who, they struggled with mental health symptoms for many years. They get themselves on a medication, say it's Haldol, which is one of the medications that we know has a higher risk of causing tardive dyskinesia. And they've tried everything else, but the side effects are just too much for them and they abruptly stop. That could also cause, I know it seems kind of paradox, it can cause it too. So I think what we really want to emphasize here, both me and Dr. Lukish, is that this is about communicating with your provider. As your provider, we are here to do what is best for you. We are here to work with you. We are not here to, say this is the only thing that's going to work. This is the best option. Like, this is a collaborative effort. And especially in a field like psychiatry, I am always weighing the pros and cons of medications to make sure that my patient has the best quality of life. So yeah, communication with your provider, really important. So how can we support either yourself or your loved ones? So as you can imagine, like with many movement disorders, such as Parkinson's disease, tardive dyskinesia, and there's like a lot of other movement disorders, it can be embarrassing. This can be a really difficult thing to deal with. And so I think what really helps is just raising awareness and stigmatization, like reducing the stigmatization through kindness and understanding that this is not your fault, and that in almost every case, there's nothing that could have prevented this from happening. And that there is treatment and there is hope for improvement of your symptoms while still being able to manage your psychiatric symptoms in a way that allows you to live the best possible quality of life. So as I've said multiple times, meeting with your provider regularly, every single time a patient is in front of me, every 3 months, every 6 months, however often we're meeting, I am screening for side effects, including tardive dyskinesia, any other side effects, and efficacy of the medication, whether we need to continue it, up the dose, lower the dose. So that's why it's so important to regularly attend those appointments and to be vigilant for abnormal movements. Don't minimize yourself. Don't minimize your symptoms. As providers, we are here to listen to these problems. We are not here to just say like, oh, well, we don't care because the medication is working. Like, this is very important for us. So if you are, on a medication, you start seeing this after a couple of months, we want to hear about it. Message your doctor, call your doctor, even if it's before your appointment time. And most importantly, as I put down here, don't panic, because as I stated before, this is not life-threatening. This can be difficult to manage, but it's not something that is going to hurt you or harm you. It doesn't mean that something bad is happening to your body or that your health is in danger. So, questions I would ask your doctor if I was concerned about this. I would say, am I or my loved one at risk for developing this? And most often, the answer is going to be based on the antipsychotic that you are on. There are many, many antipsychotics, and they're in different generations, and they all have different risks associated with them for developing tardive dyskinesia. Make sure that you're being screened at every appointment. Ask them what they would like you to do if you notice symptoms. I'm hoping that the answer will probably be, please message me right away, but do not stop or change the medication until we speak to each other. And are there safer medication options? Which there are. There's always an option to switch medications, and there's always an option to add some of these FDA-approved medications for this disease in order to stay on a medication that might be helpful for you. All right. So real quick, I want to play this video. We're going to give you guys a list of resources, including NAMI. There are also organizations that work specifically for promotion and advocacy and resources for patients living with tardive dyskinesia. This is from the National Organization for Tardive Dyskinesia, and it does a good job of kind of describing it, as well as patients kind of talking about their experience. And I think when we talk about movement disorders, it can sometimes be difficult to, we say a symptom, but like, what does that really look like? Because it looks different than other types of things. So you can see some examples.
Tardive dyskinesia typically explains an involuntary movement, mostly to the face, the jaw, the eyes.
It usually affects the mouth, the eyes, sometimes just like the grimacing of the cheeks.
The biting of the cheeks, or like if I was, eyes twitchy to her, it feels like a vice. There's something in there, but you can't see it. constant pressure.
If you were laying down for the torso, you will feel your torso go up and down.
There is numbness, burning,
There's just no getting comfortable, and you just have to move and move and move.
nerve pain.
And it's all from medicine that doctors have prescribed for it.
My journey started February 2019, and I got on Wellbutrin for ADHD and depression.
I started dealing with mental health issues around 11. They started medicating me off and on around 16, 17.
I was probably sick, my whole life, but I didn't officially get diagnosed until I was 25.
I was referred to a psychiatrist for medication purposes for my anxiety disorder by a psychologist.
And it was getting on risperidone that I started having the jaw movement.
I started showing symptoms of tardive dyskinesia that I knew weren't normal May 6, 2016.
2017, I was put on Abilify.
In 2017, I started reporting that I was having these tics.
I started getting some weird symptoms in my mouth.
In order to sleep, my feet would just go insane.
My tongue would flip upside down and push against my left side of the teeth, and it would just sit like that.
Then I started having this burping issue. I would just burp.
I went to the hospital when I first started getting sick because I didn't really know what was going on with me.
Initially, I had went to my neurologist because I also suffer from a seizure disorder. She was completely baffled, straight up told me, I have no idea.
I went to a GI doctor, gave me an endoscopy and down my stomach, nothing wrong. He said it was totally normal. And he said to my wife, it's this.
I went to my med management doctor and he accused me of being on drugs and going through withdrawal.
They would want to do a mental health evaluation on me. And this is not a mental health issue.
I ended up having to admit myself to a psych unit to get diagnosed.
They did the brain scan. There wasn't anything. There was no Parkinson's. There was no multiple sclerosis. And he's like, I don't think you're a malinger. I don't think you're lying about this. I definitely think it could be tardive dyskinesia.
They automatically put me on another medication, and they didn't know a lot about it.
It got worse as we kept experimenting with medication.
Biting my cheeks started. So even going through my journal, I'd be like, that my cheek again, my cheek can't heal.
After 3 weeks, I couldn't walk. With more than a couple steps, it was like my movements were so weird. I ended up falling, breaking both sides of my ribs.
At that time, my jaw was clenching so tight that I broke 4 teeth.
It has gotten to where I have to be physically restrained during my bad episodes. My best friend, Nikki, had to stand behind me while I sat in a chair, and I was shaking and twitching so badly. She ended up with bruises across her chest, bruises on her arms.
And I found with me, my TD kind of acts up when I get anxious or nervous.
I can feel when it's trying to come off. It feels like I'm being electrocuted from the inside. It feels like someone has a car battery hooked up to me and is every so often just up in the watch.
Basically, I get up in the morning and I lay in a fetal position, hoping that it goes away soon. It usually takes 2-3 hours every morning before it subsides. That happens every morning. I go to bed at night full of anxiety about waking up in the morning and getting up and having to go through this.
I have Crohn's disease, I have endometriosis. So I have things that cause severe pain. And then you get your TD symptoms. And it's like, okay, now I'm in pain because I can't be still from my other chronic pain. So it's like a double-edged sword.
I was having terrible cognitive problems. I didn't know what day it was. I couldn't finish a sentence.
And being an actor too, I got to the point I couldn't even talk. I had to use my phone, to talk to people.
I had to drop out of my golf league that I had been in for 30 years because every time I swung the club, I fell down.
It robs you of so much more than just your body movement.
My business went totally downhill. And so I ended up at the end of 2019 having to close my firm and go on disability.
It tore me down to the darkest depths. I can't even tell you. I wanted to die many a day. And almost destroyed my marriage because I was no longer the person I used to be.
If someone has severe TD, it could take away from their personality, and that's what takes away their quality of life.
It's a scary disease to be honest about because you do look crazy when you're having an episode.
One of the most important things is having a good support group around you.
I work with a lot of children with autism, and I've seen it where my children with ASD, half of them have parents who are extremely supportive, friends and family are supportive, and that child excels and learns everything they need to.
My family was an excellent support group.
My two older kids understand, you know, sometimes mommy's hands, arms, legs, whatever, do things that I can't control.
There's shame because you know you didn't cause it, you know it's not your fault, or you're blaming it on something else. That takes a mental toll. That is going to mess with your self-worth. That is going to mess with your self-esteem.
There's a couple of women that I talk to frequently that they get really down, and we're there for each other, and that support system and awareness and people knowing more about it, so you're not so embarrassed in public.
The biggest thing is not just for the patient to be aware of all the side effects, but also the caretaking team to be aware of all the side effects.
The newer doctors, the younger ones, I think are being trained and are understanding it more. Because when I went in, they've understood what's going on with me.
TD for me was really hard to avoid because one of the statistics I saw was that if you're Asian American or if you're Black, you have a high chance, and I'm both.
There is no medicine that can fix the dopamine receptors in your brain to cure tardive dyskinesia. You just have it. You have it for good.
I do have the option of using, I think it's pronounced Usito, and also Ingrezza, but the reason why I'm choosing not to is because I'm not ready to try a new medication, especially after developing TD.
I would literally give back every single second of sleep that Seroquel gave me to have my body be my own again.
This is your body, and this is medicine that you're putting into your body. So if you're not okay putting it in there, find something else.
I understand, and I have so much sympathy and love and compassion for the mental health community. And that really is the community I feel that has been the most betrayed because they can't stop. They're afraid that if they stop, they will have psychosis. They will end up in the hospital. They will commit suicide. They will hurt themselves. And so they are forced to continue to take this medication.
I want to get some awareness out there. It's so important.
There's not enough out there for TD. There's not enough. And the fact that National Organization for TD is the only national organization out there, it means so much more.
We just need to get it out there because I really pride myself on being a nerd and a researcher. And I felt so foolish that I did not know enough about tardive dyskinesia before.
I run up and down this busy marketplace, back and forth with my TD shirt on. And I am waiting for somebody to ask me what this is.
If you have TD, there are so many options for support. You just gotta find it and don't let yourself feel alone.
You gotta think positive in life. Life will just kick you in the butt, and you gotta either fight or not. And I chose to fight, and I'm gonna continue to fight because I got a family. You know, I got people that love me and need me.
All right. So, I want to talk about what I really liked about that video and what I really want to emphasize for the purposes of this lecture. So, I really like that there were patients who have developed this both from use of antipsychotics, which is what is most commonly going to be causing this with patients with severe mental illness, and from some of the other medications we talked about, dopamine blockers being used for GI upset. And I appreciate that these patients are not sugarcoating how difficult it is to live with these symptoms and how difficult it was for them to get diagnosed. I think our goal as psychiatrists, and especially those of us who are advocating for mental health through an organization like NAMI, is that we are here to work with you, as I stated. there are always going to be options for different medications, for different treatments, and to work with you, and to work with your symptoms. And just because there's a symptom that we may find to be something we might want to help you with, if it's not something that is a danger to you or others, we can always have that discussion. And so I think what I want everyone to really take out of this is to communicate and to have your voice be heard. Because it was definitely disheartening to hear from some of these patients about how they felt like it took a really long time for them to get diagnosed, or that the symptoms were not understood. And I'm hopeful that they're saying that some of us younger doctors, especially those in residency, that hopefully we're doing a better job of really working to collaborate with patients, which I think has been a big problem in the medical community for a very long time. So yeah, that being said, how do I, next slide here. There we go. So kind of just to summarize what we've been talking about, this is a side effect of medication that causes involuntary movements. I appreciated that in that video, they talked about some other movement disorders that can occur both during antipsychotic therapy and during dopamine blocking therapy, including akathisia and dystonia. These are things that usually happen very, very quickly after you start these medications. And they are much more intense reactions. They're kind of less insidious than TD is, where it can develop kind of gradually. And it, as I said, starts months to years after beginning the dopamine blocking medication. It can be caused by long-term use of these medications or stopping them abruptly because of the way that medication affects the dopamine receptors in your body. Early recognition is incredibly important because the sooner that we can recognize that this is happening and either start treatment, switch medications, the greater chance your body and your body's chemistry has for rebuilding those dopamine receptors in a way that is going to be helpful for you. Treatment is available and there's hope. So yeah, see. So made a list of these resources, as they did just say in that video. The National Organization for Tardive Dyskinesia is great because it is the only national organization specifically for tardive dyskinesia. There are some other resources that might not necessarily be national organizations that I've listed here. And I believe that this lecture is going to be made available on YouTube, and I provided some PDFs that can potentially be shared with you guys here today, and also be available on the YouTube link for if you are concerned that you may have or you may start to develop this. Last but not least, this is a NAMI specific toolkit, and the link for the QR code through the NAMI website for tardive dyskinesia. So that is all that we have as far as our presentation. And at this point, we would love to be available to answer any questions, provide anything anybody needs.
Thank you so much. That was incredibly informative. I definitely learned some things I didn't know. I didn't realize how many medications had the potential to cause this. I thought it was a much smaller number. And there's a couple of things you said that I really appreciate. One, that you're working closely with patients. You know, I think any one of us who's been in any kind of medical treatment has been through frustration that maybe we're not being listened to, and maybe our thoughts on a particular issue are not the most important. So we really appreciate that. And I also did really appreciate in the video that these were people with lived experience, which is what we really focus on here at NAMI. And so sharing their own experience, and then also just reminding everyone that by participating in the NAMI support groups, in the family support groups, or in the peer support groups, you know, it really supports. If you, for example, like you talked about, you know, maybe we feel a symptom, but we think, well, I'm not going to say anything because it's probably nothing, or for some reason we don't want to acknowledge that maybe we have something else going on. But that's the kind of thing that can be shared in a support group where someone else in the group, when you hear a peer say, you really should talk to your doctor about that, you really should talk to your clinician, and then you're more likely to do it. So we encourage everyone who's listening to participate in those support groups and get that kind of group support that you can get when you're addressing any kind of issues related to your own mental health or that of a loved one. So we're asking everyone to go ahead and put questions that you have in the chat so we can just make sure that we get them. I got to open the chat. I'll read them out in the chat and let's see. Let me see what we have here. We don't have any questions right now, so okay, I have questions. One of the things that I wonder about, one, I don't think a lot of people are clear on the potential to have these side effects and that information to act immediately if you start to see these side effects and talk to your clinician. So are they clearly listed in the information under side effects? Is this something that clinicians regularly talk to their patients about?
I really like that question. I'm going to be honest. I think that a lot of times as clinicians, we talk about side effects that are more common and less disturbing because we do not want to scare our patient away who is coming to us saying, I need help, from trying something when the percentage of developing this is so low. So in a case like this with a movement disorder and tardive dyskinesia, we don't see it a lot, but when we see it, it is serious. It is disrupting. And a lot of times, especially in the psychiatric community, when we have a patient who is sitting in front of us who might be having severe psychosis or acute mania, and they want help and we want to help them, and we start these medications, we don't want to scare them with, okay, this medication is going to help you finally feel stable again after feeling all of these terrible, because just as much as tardive dyskinesia is a terrible thing to live with, so are these mental health disorders that we are treating.
Right.
So yeah, I agree that it's not something that is necessarily overtly warned about. And I think that what could really benefit patients in the long run is for us to develop a way of warning while not frightening away from the help.
Right. Right. And then another question I have is so one of the people in the video mentioned and once this develops, well, first of all, how much influence so we know with psychiatric drugs, there is often, because of insurance issues, there are some stepped prescribing practices that may lean towards, or if I may be wrong, but that may lean towards drugs that are potentially have stronger side effects. And then it's a difficult thing to, once you're on a medication that seems to work for you, the idea of changing medications is one that can be a risky proposition, especially given the nature of the illness. So can you talk about that a little bit? And maybe that's two completely different questions, but maybe not, because how much influence does insurance have on what's prescribed and then the idea of changing?
That's a really fair question. A lot of times when we are choosing a medication to prescribe our patient, we are going based on what we know either their insurance is going to cover or they are going to be able to afford. And we have a problem in this country with insurance and availability and the cost of medications. This is something that we as physicians, and especially someone like myself, who I'm very passionate about community psychiatry and advocating for marginalized patients. A lot of times they come to us unhoused, they come without insurance, and they need help. And the only thing that we can give them that they're able to either afford or take long term is a medication that is going to have a higher risk of causing tardive dyskinesia. So this is very much an institutional problem as well. You know, this is political as much as this is about medicine. And I think us clinicians are fighting this on a daily basis. And we want nothing more than to prescribe the most expensive medication with the lowest side effects. But the option is either not to give our patient any medication or that we're going to weigh what's going to be in their best interest. But it's a difficult subject, and it's something that needs to be talked about. Yes.
Agreed. And NAMI National, just so everyone knows, is involved in lobbying to change, you know, these rules and these laws so that this kind of thing can be addressed more easily, so that insurance coverage is not stepped in that way. So just anyone who's interested in that, if you go to just NAMI.org, we are constantly working with the federal government, and then we at NAMI Miami are working with the state government to try to improve these things, as well as many other advocacy organizations that we are connected with and work with. So that is very much part of our mission and part of what we do. We have a question in the chat. She says, I have TD and figured it out from seeing commercials for it. But now I'm hearing that it is a permanent disorder. Dr. Google and my psychiatrist said it is rare for it to become permanent. So is there some that's temporary or mild compared to, is it connected with how long you're on the medication or?
Yes, I would say it's not always permanent, but it's usually persistent and it's often irreversible. And yes, it's correlated with how much longer you're on the medication. So, you know, once you become aware of it, it's important to have that conversation with your doctor. That's one of the most important takeaways that we want to have from this talk is open communication with your doctor. But unfortunately, it is more often than not, it is permanent and irreversible, but there is treatment and it can get better with the treatment.
Okay, and then the other question I have is, we know there are some newer drugs or a newer drug that seems to have not have this particular side effect. Is that accurate or?
Absolutely.
Okay.
Absolutely. And I did find it interesting that in the video that we watched from that organization, and this is to just show that everybody's body is different, body chemistry is different. The medications that were listed that I heard, risperidone, Abilify, Seroquel, those are the medications that we know have the lowest risk for development of tardive dyskinesia. That also includes clozapine, which is rarely used because it has a really rough side effect profile. But for patients that respond well to clozapine, it is their miracle drug that changes their life. And allows them to be able to function. So what all of those medications that I just listed have in common is there's something called second generation antipsychotics. So they work on both dopamine and serotonin receptors, while as the medications that have classically been known to have like a greater chance of causing this, it's an umbrella term called extrapyramidal side effects, and it includes tardive dyskinesia as well as akathisia, dystonia, Parkinsonianism, are these first generation antipsychotics. That's going to include Haldol and Thorazine. Those are the ones that we most often see. You don't see, there's some others that you're rarely going to see nowadays. But yes, there are some new drugs coming out that work on a completely different mechanism that do not have the side effect because they are not working specifically on dopamine antagonism. And this is kind of our hope for medicine that, psychiatry as a practice is much newer than a lot of these other specialties. We've only been working with these drugs since Thorazine, which is our first one in the 30s. So we're behind as far as the other specialties. And it's really encouraging to see these new medications come up with these new mechanisms that we didn't know work yet. And so yeah, there's the hope for it.
Well, that is great news. And again, we know that insurance has an impact on prescribing those.
Yes.
Another hurdle to get over, but we are here for the fight. And do we have any other questions? We do. Is Latuda one of the meds that can cause TD?
Yes. Latuda is a second generation antipsychotic. It does not have the lowest profile for tardive dyskinesia. The medications that if I had a patient that said, I am really, really worried about tardive dyskinesia, I absolutely can't have it. What is the one that's going to be the best that you would give me? I would give Seroquel or risperidone, and sometimes Abilify. Latuda is still safer than first generation antipsychotics. And Latuda is also a miracle drug for a lot of people. It's great for bipolar disorder. It doesn't cause a lot of weight gain. There's a lot of good to Latuda, which is why a lot of psychiatrists choose it.
Okay. Okay, so another question, is it mostly antipsychotics that cause TD? We did mention that there's some, you said gastro medications that can cause it.
Yeah.
Is
so there
that
are-
the same? I'm sorry, go ahead.
No, please finish.
Well, I was going to say, is that the same mechanism? Does a gastro medication work on dopamine receptors?
Yes.
Yeah.
So
Okay.
the mechanism is exactly the same. It has to do with the dopamine antagonism. The reason why it's mostly antipsychotics that are causing TD is because a lot of times these dopamine antagonists that are used for GI problems are anti-nausea medications. So you use them for 3 days after surgery, or
Okay.
some sad cases you're using for a couple months when you're undergoing chemotherapy. But antipsychotic treatment is often many years. But as I also stated, it doesn't have to be. There are certain, temporary psychotic disorders such as substance-induced psychosis that go away with time, which is why it's important to always be following up with your doctor and making sure that you're on medications that you need to be on and tapering off medications that you don't need to be on.
Hey. Right. Another question, how about Effexor, Wellbutrin, or Ingrezza, or Austedo?
Effexor and Wellbutrin should not cause TD, should have no risk of TD at all.
Okay.
I'm glad to hear that Ingrezza, Klonopin are helping though, because those
Yes.
are the Austedo, Ingrezza are first line, Klonopin is second line.
Okay. Great. Stacy says thank you. And we just, Stacy, who's dropping questions in the chat, I would encourage you to, if you're not already doing that, please attend some of our support groups so you can speak with peers about their experience with these things, and also take a look at the Tardive Dyskinesia organization, because I believe they have support groups also, so it's very targeted there on managing that illness. And the big lesson we're learning here is talk to your physician, and if your physician doesn't listen, it's fine to get a second opinion, right? It's fine to talk to someone else. Don't not talk to a clinician, Don't try to solve the problem yourself but I think we all know that having a clinician that you're truly comfortable with, and it is really half the battle, I think, for all of us, and someone who is accessible. So we only have a couple of minutes left. Dr. Lucas, is there any closing remarks, any last thoughts you'd like to share with us?
The big thing is there's hope for this disorder. I think the biggest thing that, also we wanted to emphasize was just communication with your provider is important. When we experience movement symptoms or some of the symptoms that comprise TD, it can be stigmatizing. It can be embarrassing to share with your doctor, but that's what we're here for. We want to, listen to you and be there for you. So just keeping the communication line open and being aware that this can be a side effect of medications, but these medications oftentimes, we're prescribing and for, because you need to be on this medication, unfortunately. So, it's a known risk, but there are good treatments available.
Great. And Dr. DiLorenzo, any other last thoughts from you?
I think I've probably said all there is to say, but I just really want to thank this organization for having us here to talk about this. Please, everyone, if you can attend the NAMI walk. I am a bad NAMI member of my program because unfortunately we're going to be in San Francisco for the American Psychiatric Association conference, but there are going to be other residents and support from our program, and we would love everyone to join us.
Well, we knew about that. We knew some of you won't be there. I do want to thank both of you and for joining us. And we know we're going to be hearing from you more because you're around for a while, given where you are, both in your training and your practice. And that's really exciting to me. I look forward to speaking with both of you more about the work you're doing and your experiences, because I saw some things in the introductions that we gave that I'm really fascinated by. Just to everyone on the call, you do need to register for the walk. You can pre-register now, or you can register on site. There's a lot of people there. You can see the pictures behind Dr. Lukish. So that's how many people are there. So it's a very safe place. If you're a person with a mental health condition, or if you have a loved one and you're not used to talking about that publicly, you are in a very safe place, and the atmosphere there is really, truly pure joy. And our team are there. We have the NAMI outreach tent, so you can talk to people one-on-one personally and get to know us a little bit if that makes you feel more comfortable, which I know it will, because that's what we do. I'll be there. And so flag any one of us down. Our shirts say staff on the back, and we are happy to talk to anyone, and call the office, call our helpline, because we're also completely, we're there to talk and to listen, more to listen actually, but we'll help you with anything that you need. So again, thank you both so much. Thanks to everyone who tuned in. We will be posting this on YouTube probably after the walk, right? Maybe before, but right now we're in after the walk mode. So, and just thank you, and everyone have a great night.
Thank you, everybody. Thank you so much for having us. Have a good night.
Oh, and thanks, Eileen and Sophia, for all your hard work.
Thanks, everybody.
All right. Good night.